All right. Well, thank you guys, everybody, for joining us this evening. My name is Dr. Jordan Tate, and I have an honored guest here, Hunter. I'll allow him to introduce himself.
Hey everybody, my name is Hunter Malagary. I am the local ReActiv8 therapy manager. I work with Dr. Tate. I'm at all the implants and all the program and all the patient follow-ups. So I'm I guess the local expert behind Dr. Tate, but I'll be there along the way.
So Hunter works with a company called Mainstay Medical, and they have a product called ReActiv8. I first heard about this product at one of our huge conferences called NANS in Las Vegas in 2016, I think it was. And at that time, this was not available in the US. The company is based out of Ireland, and they have been involved in major research trials in Europe for the better part of the last decade plus, and have now been made available and commercially available here in the United States after getting FDA approval. And I've also had the privilege of engaging with them on some research studies as well that they are doing to continue to help expand their data collection of this amazing product. So it's called ReActiv8, and it's restorative neurostimulation. So this is different than spinal cord stimulation and some other kinds of stimulation. So if you've heard of stimulation and you're immediately thinking like, oh no, not this again. Well, this is actually different. So we're going to explain how and why. And that's me. So interventional pain specialist. If you don't know who I am, I'm Dr. Jordan Tate. I'm a physiatrist and pain medicine specialist, double board certified, practicing in Jasper, Georgia at Southern Pain and Spine, where I serve as chief medical officer and co-owner of the practice. We also have locations in Gainesville, Athens, and Noonan, if you're joining us from any of those locations. We're gonna really just get into the nuts and bolts of these slides, and we have a couple of videos as well. There is a chat function, which some of you have already found, and you can start typing in questions as they pop up. At the end of the presentation, we'll review those questions and then engage in some frequently asked questions and dialogue. So if you have any questions, go ahead and type those down there in the chat box. Okay, so if you're on this webinar, it may be because you have been suffering from chronic low back pain, or somebody you know and love is suffering from chronic low back pain. What we know about CLBP is that it is one of the most common reasons people go to the doctor or miss work or school or file for chronic disability. And it's also one of the most challenging types of pain we deal with because it can be very complex and often doesn't respond to typical treatments. We're going to start with this video here. Let's see how this works. I may have to be quiet while it starts. All right, here we go. Hopefully everybody can hear it.
We actually can't see it, Dr. Tate.
You can't see it, okay?
Still seeing your
still seeing my other screen share, probably. All right, we'll keep going, and then we'll try and go back and play that one because we were actually thinking about skipping that one anyways.
There you go.
It's a little bit complex. So what the video talks about is the deep muscles of the back are called multifidus muscles. And in somebody experiencing chronic low back pain, these muscles begin to weaken and atrophy, leading to worsening dysfunction of chronic pain, allowing more stress to accumulate on the already degenerating and painful spine, leading to chronic pain. So what we see here on the screen is that some patients have different types of pain patterns. One type is sciatica or nerve pain, and that's often from a disc herniation and may need to have back surgery or epidural injections. Other types of pain are going to be more what we call mechanical pain, which means that it hurts when you're moving and loading your spine, and is often staying in the low back. So that's what we mean by axial, is that it's located around the spine and not so much of the shooting low back pain. So if somebody has shooting low back pain or sciatic pain going all the way down to the foot, many times that type of pain syndrome would be taken care of with a stimulator called spinal cord stimulation. But if you have more focal or what we call axial low back pain, you may be a better candidate for a more specific treatment that can actually restore stimulation to those weakened muscles. And that's what ReActiv8 is. So you see on this picture in the right-hand side, this drawing of the male is shown to have red hot pain of the low back and upper buttocks, not shooting down the legs. And then this ReActiv8 is a stimulator that's going to actually work on restoring the function of the muscles, as opposed to just overriding the pain signals. So we know that most patients with chronic low back pain actually do have some component of mechanical pain and load-based pain, as opposed to what we call neuropathic pain. And so many patients who have chronic low back pain will fall into the category of potentially responding to a ReActiv8. All right, let's see. If we do a new share here, maybe it will let me go to the desktop. Yeah.
I can also share if you need.
Okay. What are you seeing? Still that video?
We got it. You go to video.
Now you're getting the video. Okay, so this is the video that we skipped. So hopefully this will explain what I just tried to explain. And it may be a little complicated, so we'll break it down afterwards. But we'll let this play for the next 2.5 minutes.
Gloria has a healthy and functional spine. Gloria consciously tells her body to straighten up as she bends during stretches. As this happens, her back is communicating with her brain on what is happening with the alignment and movement of her spine. Her brain receives these signals and then automatically activates the deep stabilizing multifidus muscles to help support and align her spine while she stands back up. James has an unhealthy spine with multifidus dysfunction. He's on his feet all day working around his house, but his body is not maintaining balance and good alignment due to the lack of communication with his brain. Instead, his body compensates by overworking his superficial muscles to maintain posture and stability. Unfortunately, these muscles are not made to hold the spine for such long periods of time and soon become tired and sore. Unlike the deep multifidus muscles, these superficial muscles don't function well stabilizing the spine. Therefore, the spine spends more time out of balance, being overloaded, and causing pain. James consciously tells his body to straighten up as he bends down to pick up his dinner out of the oven. Unfortunately, his back is having trouble communicating with his brain to properly control his alignment and movement while he straightens up. The part of his brain that controls the deep stabilizing muscles is inhibited, dysfunctional, and fails to activate the supporting multifidus muscles which help control the spine under this load. James is very sore at the end of his day and his body aches. He has to take pain relievers to try and mitigate the pain. His wife Gloria is worried about his condition and wants him to go see a specialist. She sees a new restorative therapy which may help reconnect the communication between his brain and spine. She convinces James to seek treatment.
All right, are we back on our slides?
Got it.
Got it. So I think that video does a great job of explaining the connection between the multifidus muscles, which are the deep core muscles that are supposed to help stabilize the spine, and the dysfunction that occurs in the chronic pain cycle. So as we see here, this is a depiction of that cycle. So your chronic low back pain might start with an overloading injury, a disc bulge, or maybe a slow progression over time that leads to some arthritic changes of the spine, what we call degenerative changes, or spondylosis or facet hypertrophy. And over time, that chronic pain and inflammation will cause the muscles to stop firing appropriately, what we call myogenic inhibition. And when the muscles don't fire appropriately, those signals to keep the spine safe aren't getting to the brain. And you lose that neuromuscular control, that reflex arc that occurs between the deep muscles of the spine and the brain. And with that altered neuromuscular control, you start to have weakness and dysfunction of the muscles. And what we see is that this actually can occur as soon as 10 days after the development of onslaught of chronic daily low back pain. And on the right, we see pictures of, these are MRI slices of patients' low back or lumbar spine. And on the top picture is a depiction of what looks like a normal myogenic bundle or multifidus muscle. Hunter, how would you describe those muscles? What do they look like?
Yeah, so I mean, if you're looking at the pictures, the first one is like that nice, clean fillet, not much fat in there. Your second one, which is a little bit more atrophy, some fatty infiltrate there. Yeah, it looks like a good marbled ribeye, maybe. And then down at the bottom, you've got a lot of fatty infiltration there. So maybe like a Wagyu, little flavorful steak there.
Yep. So there's a lot of food analogies involved in reading MRIs, but this one is very spot on. So we're looking at the round muscles in the bottom part of the MRI report image here, and as he mentioned, you know, the first one that looks like that top sirloin fillet, but as we like our steaks to have some fatty infiltration in them and have marbling in them because it, you know, allows them to taste better and be softer. That's not really what you want in your low back. You don't want your low back to be soft and pliable. You want it to be strong and durable. And so what we often see in patients who have chronic low back pain when they come and we review their MRIs with them is that their multifidus muscles have begun to shrink or atrophy and have been replaced by infiltration of fatty tissue. And when somebody has chronic pain and they especially exhibit a lot of mechanical dysfunction, so it hurts when they bend and twist and try and lift heavy loads and get through their day, if they have multifidus dysfunction, they're really unable to safely protect and activate those muscles and protect their spine. And so they have more friction occurring in their joints. They have more load and stress occurring on their discs. And I think that last video that we skipped kind of goes over that pretty well. So I'm going to try and go back and play that one real quick, if we can. Don't know where it went. Hold on. Here we are.
In a healthy, functional back, the brain sends motor control signals to the back muscles, while the back muscles return sensory information in order to perform everyday activities. This communication loop between the brain and muscles is called neuromuscular control and consists of muscle recruitment and sensory feedback called proprioception. We use neuromuscular control to consciously control our superficial back muscles when doing things like exercising. Large muscle movement activities, like bending over to pick something up, is consciously controlled from the brain. We also use neuromuscular control to subconsciously control our deep stabilizing muscles for smaller micro movement or stabilization activities, like brushing teeth over the sink, washing dishes, reaching up for something, or having to maintain a standing or seated position for an extended period of time. Large movement activities utilize the outermost superficial back muscles, called the erector spinae group, which are most often controlled with our conscious thought. Critical spine stabilization during movement activities utilizes a deep multi-layered core muscle group called the multifidus muscle group in our lower back. This stabilization is automatic and is mostly controlled subconsciously. Neuromuscular control can become muted or inhibited due to injury. This causes our brain to send little to no signal to the muscles, as well as ignore important proprioception from the muscles. This results in our muscles failing to properly function to stabilize our spine and spinal column correctly. This muted or inhibited communication loop can cause excess muscle fatigue, improper loading on spinal joints and discs, resulting in mechanical chronic low back pain. This cause of mechanical chronic low back pain, stemming from the loss of neuromuscular control and multifidus dysfunction, is often misdiagnosed and can be confused for other back pain pathologies.
Okay, so hopefully we have gotten that pretty good. Let's see. Try and get back to our presentation. So I know that introduced some novel and complex concepts that maybe many of you have never heard of. And I will say it's actually, Hunter and I were talking before all of you got on, these concepts are things that many physicians, even interventional pain physicians and spine specialists, neurosurgeons, have really never thought about or wrapped their brain around. And in fact, have always been taught, look for the pain generator, turn down the pain signal by, injecting into the facet joint or into the sacroiliac joint, or, fuse the spine and it won't move and therefore it won't hurt. And, this is really just a very novel approach at treating chronic low back pain. Let's activate those deep muscle tissues and override the pain signals and allow the back to get stronger. What everybody has always tried to do is send you to physical therapy, right? And sometimes that helps a little, but many patients are unable to tolerate physical therapy because the pain is overriding it and they're just so debilitated. So this allows you to have the outcomes of physical therapy without the performance of physical therapy. And then hopefully to get the finishing touches, you can then engage in a rehabilitation program once the pain is under better control. So currently, if somebody walks into my office with chronic low back pain and they've really never tried anything at all, I check and make sure, have you given it enough time? Have you allowed your natural body mechanisms to try and heal some inflammation or pain? Have you used basic things like ice and heat or TENS units? Have you tried a course of physical therapy or a visit with a chiropractor or a massage, acupuncture? And if you've done those basic things, then usually we move on to trying more advanced procedures such as epidurals or radiofrequency ablations. And of course, medications are in the mix there as helpful adjuncts to get you through the process. For many patients, conservative therapies and basic injections are good enough and get the job done. But about half of our patients are still left, kind of scrambling for answers and trying to figure out where to go from there. And that's where we get into our more advanced procedural options or spinal surgeries. And most patients really want to avoid spinal surgery at all costs, either due to fear or really the definitive nature of spinal surgery. Once you fuse the spine, you can't unfuse it. And so the idea of really maximizing our minimally invasive non-surgical options is flourishing right now. And patients are doing much better for it, not going straight to spine fusions that they can't undo. Also, many patients fall into the category of not responding to these current options for chronic low back pain, but then not having surgical options offered to them either. Either the surgeon tells them, they have too mild of problems, or the problems are too diffuse across the spine. There's not one good target to operate on. Or for medical reasons, you're either, too overweight or can't have general anesthesia or something like that. And that's where potentially a procedure like this might fit in better, that can be done without having to go to a hospital and have a major spine surgery. So patients who are good candidates for ReActiv8 generally have chronic refractory low back pain, meaning they haven't responded to conservative therapies. Many of these patients will have mild to moderate or even severe disc degeneration or degenerative disc disease. Many patients will then have facet arthritis or arthropathy found on their MRI. And patients can have disc bulges and even small herniations. And some patients even have alignment issues, what we call spondylolisthesis. In patients who have a grade 1 spondylolisthesis, Hunter, what kind of outcomes are you seeing for these patients?
Yeah, so I mean, those stabilization issues, work really well with ReActiv8 because clearly we are able to stabilize and fire that muscle and get it back operating the way it's supposed to. And those patients did really well. Out of all of these groups here in our B study, with these other observed pathologies, the spondy patients actually responded a little bit better than some of the others. That's the only one that made a difference, just because we're able to stabilize the spine.
Yep. Yeah, those patients kind of stand out as being super responders to ReActiv8. All the other patients have the likelihood of doing quite well. But what we have seen is that these spondylolisthesis patients tend to respond faster and more robustly, which is pretty interesting. So we talked about treating the cause and not just the symptoms, and focusing on rehabilitation and activating control. So how do we go about doing that? Well, it's basically 2 leads that are implanted outside of the spine. So what's different about this than a spinal cord stimulator is that, in fact, it's safer. For one thing, we are implanting the leads just deep to the multifidus muscles and parking them right on the back part of the spine. So we're not entering into the spinal canal, and we're not getting close to any of the spinal nerves. So there's really no risk of major damage or disruption to the spinal canal or spinal nerves, which makes this a much safer procedure than spinal cord stimulation. Not to imply that that's an unsafe procedure by any means. But this is considered peripheral nerve stimulation and multifidus stimulation. The leads then are connected to a battery that is implanted, what we call an implantable pulse generator. So very similar to patients with a pacemaker or with a spinal cord stimulator. This is an implantable battery device. And that usually is implanted in the above the waistband or just below the waistband in the upper buttock, and is placed under the tissue so that it is seated nicely and is not bulging out of the skin unless you're like 80 pounds. I'm going to let Hunter kind of explain the patient experience with how this works and how you utilize the device.
Sure. So ReActiv8 therapy is a patient-controlled therapy where you have a wand or a remote that turns on the therapy twice a day. Most of our patients do this morning and night. We program the device to your comfort level. We want it to feel like a deep tissue massage because you are getting contractions in the muscle. You do feel it, but it is very comfortable. It's at a low power. And our patients, when they start to turn it on in the morning, what they typically do is set their alarm 30 minutes early, roll over, place the wand over the device, start their therapy, and a lot of them go back to sleep. So it is a comfortable therapy. It's not shocking you. It's not overstimulating you. It is a comfortable programmed therapy specifically to your perception and your needs.
Yep, and it's used 30 minutes 2 times per day. There's no need to use it any more than that. Some patients over time will liberate themselves from needing to use it twice a day, every day. And patients will then, over time, once their pain is under better control, might utilize it if they have a flare-up, or might peel back to using it once a day. But in general, this twice a day session for 30 minutes is the standard, at least for the first 6 to 12 months of use. That's what we're recommending. And so how does that work? Well, it's activating the muscles. And just like you go to the gym and you juice your guns, as they say, right? You build your biceps, you get the muscles to be bigger, and you burn away some of that fatty tissue, and you help to improve the control and the function and the stability of the multifidus muscle, that then reduces the loads on the spine. And so even if the spine has 5 degenerative discs, every disc of the lumbar spine is degenerated. Some of them are bulging, some of them are torn. That has resulted in having chronic facet arthritis at every level. As long as you don't have very severe spinal stenosis, there is a patient like that, like you, that has been implanted. So we don't recommend this for somebody that has maybe severe spinal stenosis and is having weakness of their bowel and bladder and other things. Those are patients that really should be having spine surgery. But if you're somebody who is walking around with chronic daily refractory low back pain, and you've tried more conservative things like going to the gym and getting a massage, and that hasn't helped you, and you've tried things like nerve blocks and ablations, and that hasn't helped give you long-term relief, that's where this fits in. So
Dr.
we
Tate,
would
I think,
evaluate, what's up?
go ahead, finish what you're saying.
I was going to say, we would evaluate your MRI to confirm that you fall into the right category. So if you would instead need to have spine surgery, we would send you to a spine, to the neurosurgeon, and recommend that course of action. But if you're not needing spine surgery, it really almost doesn't matter what the MRI shows. There's many patients out there that have mild changes, and many patients out there that have multi-level severe changes that have done really well with ReActiv8.
So I think you actually just kind of answered this question, but Mary posted in the Q&A section, what if you have all of those issues going on? And I think she's referring to the slide, modic changes, spondy, all of the other pathologies we observed in the B trial. So I don't know if you want to, I think you kind of answered that, but
Yep.
if you want to dive into.
Yeah, I mean, we'll go through some of the data in just a second, but in the patients that have been studied in numerous research studies over the past, I don't know when the first enrollment was, but like 15 years, I'm going to say. I think
it
it's
was like
fair.
12. Yeah.
Okay, 12 years is fair. And then in my experience utilizing this device, I haven't seen major differences in patients who have very severe pathologies and very mild pathologies, or they have multi-level grade 5 degenerative disc disease with modic changes and disc bulges. They still do well with this device if they meet the criteria, which we're going to go through in just a second.
Thanks for the question there, Mary.
So what we're seeing is that in the patients who have utilized ReActiv8, that when we implant the device, this is something that requires time to work. It's not going to immediately switch off all of your pain signals, because that's really not what it's meant to do. What it's meant to do is to rebuild the muscle in your low back. And so, as you can imagine, just like you don't go to the gym one time and walk out Arnold Schwarzenegger, it's going to take time to get your results utilizing ReActiv8 every day, twice a day. But what you see in these studies here are patients who started with chronic low back pain scores of 7 out of 10 on average. And by 6 months, they were at 3.5 on average. And at 24 months, their scores were down in the 2s. We consider scores in 2s and 3s to be curative rates. I think most people who've never had chronic low back pain, if you put them on a score from 0 to 10, would say that they often experience somewhere in the 1, 2, and 3 range of chronic daily low back pain, but don't even consider themselves chronic daily sufferers. Does that make sense? Hunter, would you agree with that?
Yes, I would agree with that.
I don't know if you're
that-
old enough to agree with that, but anybody
come
who's
on.
gotten to age 32 knows that, your low back hurts on a regular basis, right? So I think if we can get patients out of the severe and moderate ranges, we've basically gotten them down to curative back pain rates if they're living at an average of a 2 out of 10. And as you see, this is something that continues over time. And in fact, their reductions in pain continue out, that they were studied out to 36 months in this published data set, but their functional improvements actually continue to get better and better. And these initial baseline, this Oswestry Disability Index, or ODI, the initial baseline is in the severe crippled range of function, and then are becoming mildly disabled. And so it's really a return to normative levels that is basically at 3 years, these patients are acting like the everyday patient out there in America with their, little bit of aches and soreness at the end of the day, but really have regained their function and ability to chop down. How many trees was that, Hunter, that our
It was
patient chopped down?
123.
120 trees that he chopped down, and that was prior to him getting to his 6-month mark.
Yeah, it was like right around his 3 months. So
Yeah, he was already feeling so much better that he went and chopped down 120 trees. And now he's almost at his 12-month mark. And he told me the other day, I don't even know what chronic low back pain is anymore. He said he basically just feels like that was a bad nightmare that he's woken up from, but that he had experienced for 10 years. So quite amazing recovery. And we're seeing that in most patients, that if you have a desire to come off of your pain medications, that you can voluntarily eliminate and reduce your opioid intake because your pain relief is significant, and that's in 70% of patients. And some patients don't want to come off their chronic opiate therapy. They utilize it for other things, shoulder pain, in addition to their back pain, etc. And so, it's not to say that if you get relief that you have to come off your opiates, but if that's your desire, that's something for sure that one of the goals is to get you away from needing to come in and be seen every month and getting pain pills and that kind of thing. And so overall, we talked about the safety of this. It's has a great safety profile, especially compared to other neurostimulating options on the market, because we're not invading into the spinal canal. We're staying in the back part of it. So we're really just going through skin and muscle tissue. And so if you were to have a bleed or an infection or some big complication that can occur anytime you do a minimally invasive treatment like this, it's not going to be as difficult to recover from, because we're not invading into the more sensitive structures of the spinal canal. I think we're getting close to some of our concluding slides, and then we'll look at some of the questions that are accumulating in the chat box. So again, go ahead and start typing your questions in now. But that overall, we have found that ReActiv8 is a safe and effective way to treat patients that have mechanical low back pain, and give them more progressive long-term improvements. And I think there's a few slides on how we as physicians help to select patients who are going to be the best candidates for this. And so this is really based off of, the large data sets that have been accumulated in all of this research studies. And so most of the patients, if you want to get the results that they got, if you best fit the same profile, then you're statistically likely to get the same results. And so those patients generally had mostly back pain with very little leg pain, especially leg pain that radiated all the way down to the foot, like we talked about. And we're lacking a lot of that, like severe shooting, radiating pain that was constant. Most patients had pain more than a year. And most patients, their MRI showed some of that muscle atrophy in the multifidus muscles. and the patients were not current surgical candidates. So they didn't have unstable spines. So we'll order something called a flexion extension film. And if your spine looks like it's sliding every time you bend forward, that's called an unstable spine, and or an unstable spondy or spondylosis. In patients like that, really, it's recommended that you do get the fusion. Those are patients that do well with spinal fusion. And then patients who have really severe stenosis, where the narrowing of the spinal canal is so bad that the nerve signal is not getting to the legs, severe spinal stenosis, that's also not a great candidate for ReActiv8. And then this really hasn't been studied in patients who've had major lumbar spine fusions already. It's not to say that it couldn't be done or tried, especially if you were out of other options and we really felt like this was the best thing for you. It's just that we don't have as much data or evidence to support the use of this device in somebody who's had major lumbar spinal fusion and have hardware in their back and things like that. We have an ongoing study. We know that patients who have small surgeries like laminectomies and discectomies can get this device and still do well. The data is looking to be supportive of that assertion at this point. Wouldn't you agree, Hunter? Did I say that okay?
That you said it perfectly.
Okay. And so if you have back pain, muscle spasms, or feeling of instability that seem to be getting worse with time, and if you have back pain or spasms when doing small tasks like brushing your teeth or washing dishes, reaching for an item, if you get a lot of stiffness, especially first thing in the morning, or when you stay in a position for an extended period of time, like driving in a car or riding in a car, or sitting at your desk, or even standing, and your back starts to get really increasingly painful, especially with that feeling of muscular squeezing and back spasms, and you're constantly finding that you need to shift your position or stretch out your low back to get relief, that might be a suggestion that you would be a good candidate for this. And then we would do some physical assessments in the clinic. This is an example of 3 different tests that we perform. And if they test positive, that's really has been shown clinically to be an indication that you would do really well with this device. You can still have negative, these tests can still be negative, and you can still get the device and you can still do really well with it. But just scientifically speaking, and research studies, patients who got the device had these tests were found positive. And we talked about the MRI, whether it's moderate, mild, or moderate, or severe atrophy. Just the presence of atrophy alone is suggestive that the multifidus are probably not functioning the way that they should. And so this is, yeah, this is for Hunter to explain.
Yep. So we have what's called patient partner. We call it our ambassador program. So we partner, say you have a 60-year-old female who's interested in getting ReActiv8 or whatever it is, and then we can partner you with another 60-year-old female who has had ReActiv8, somebody similar demographic, similar situation, similar age, that can speak to their experience, what they went through, their process, and you can talk one-on-one with them about how they reacted and how everything went for them post-op, and how they're recovering now. So this is, you want to scan that QR code, or there should be some brochures in Dr. Tate's office, or you can follow a link to our website to sign up for the ambassador program, just to learn more and get more comfortable with it, because it is an implantable device. So yeah.